There we go. It's going. You can start whenever.
Thank you very much, Rob. So I want to welcome everyone to today's meeting. I'll call the meeting to order. Madam Clerk, I think, do we need to do a roll or?
No, we have everyone here except Councillor Millen, and I will advise when he joins.
Excellent. Thank you, Madam Clerk. Is there any declaration of interest? Many of the committee members? I see none. If one should arise, I would ask you to declare it at that time. And we turn to item number 3, business arising, review of work to date. I want to thank the staff for putting this document together. It's a terrific idea. I really like having that to say, okay, that takes stock of where we're at. Yeah. Has everyone had a chance to peek at that document, or do you want to take a chance to look at it now? And if so, is there any comment coming from that document? And for our guests, you probably are able to see what we've been doing so far. I don't know if you have the document.
Mr. Chair, Randy Schertzer actually has a short slide presentation that he prepared just to provide an overview of, from the last meeting, the additions to that document. And I just will note that Councillor Millen is now with us as well.
Excellent. Welcome, Councillor Millen. And Randy, you have the floor. And Randy, if you could as well, just for the benefit of our guests joining today, or perhaps people joining for the first time, you're going to give us a slide presentation, but just to give a bit of an overview of what we've accomplished today.
Yeah, thank you, and good morning, everyone. So, what this task force has done to date is identified a number of key themes that we want to have presentations on from various delegations, including delegations today, as well as previous delegations. And what we're trying to do is capture some of those discussions through what we're calling a recommendations and opportunities document. And that's linked on the agenda today. Basically just to capture some of those discussions, capture some of the potential opportunities and recommendations that may come out of each of these discussions, and which will lead towards a final report that this task force will prepare, will recommend, and provide that then to council as a recommended final report on some action items and clear action items that will be identified to address some of these key themes. Everything from poverty. So the last task force meeting was around poverty and community safety and well-being. And so the last discussion was we've added to the document, the recommendations and opportunities document. We've captured some of the discussions and the key points that were raised as part of those presentations from Jill Umbuck and Sarah Cowley. And we've tried to identify some of these. And there's definitely some connections with some of the themes already that we're seeing in the discussions. Everything from affordable housing, addiction and substance abuse, mental health, crime prevention, housing and homelessness, poverty and income, they all interconnect. And so you'll see, I think, around the themes, although they're structured in themes, the task force, a lot of these connect together, and a lot of the recommendations and opportunities then will also blend together to try to address some of the challenges we're seeing in some of our communities, especially obviously in Hanover and Owen Sound being the focus of this task force. After each meeting, like I said, we summarized some of those discussions, and then there were also some questions around further research requested. And so that's what this presentation is here. We've some of the questions around what is the definition of households, for example, in the census data. So based on that, private households refer to a person or group of persons who occupy the same dwelling and do not have a usual place of residence elsewhere in Canada or abroad. So unless otherwise specified, all data and census products are for private households only. So that was one question that was raised as part of the last meeting. There was also questions around, can we break this down further in terms of type of households? Like, what are we seeing in terms of single person households or 2 or more occupant households, especially around this threshold that this task force identified in terms of those households earning less than $30,000 annually. And so here's just a slide that shows, again, the breakdown that we presented previously in terms of the income for per households by municipality, and the total of households there you can see. And as you can see in Owen Sound, we just have just over 2,500 households in Owen Sound, and 750, just over 750 in Hanover. West Grey and Meaford, as you can see, are number 2 and 3 on this slide. And so the question was, can we break down some of this information further in terms of the types of households? Are these single person households, these two or more people? Can we break this down further? So what we've done, and when I say we, Brad Noble, our planning data analysis coordinator, has done is take a look at some of the data and look at using the estimates from the breakdown of 1-person household, 2-person households, 3 or more person households, use those percent thresholds to break down these numbers further. So taking the 2,500s in Owen Sound, for example, using those percents of households to break it down in terms of just to provide an estimate of what we think are the breakdowns of those household types. And as you can see, in terms of 1-person households in Owen Sound, it's just under 1,000 out of those 2,500 households that are earning 30,000 or less. For 2-person households, it's 920. So you can see almost 2/3 of the households have 1 or 2-person households. So this goes back to some of the previous data that was presented to this task force, as well as the Affordable Housing Task Force, is that there's a core housing need in Owen Sound for sure of single female apartments, female households over the age of 55. And so this is, again, correlating some of that information in terms of what we're seeing in some of this other data, as well as data we present in the past. There's definitely a need for single apartment households, especially in this category of those people earning 30,000 or less household income. In Hanover, the numbers are similar, but you can see it's slightly less for 1-person households, a little bit more in 2-person households. But you can see, again, the bulk is 1 or 2-person households within the category of earning 30,000 or less income. We also dug into some further information, sorry, I'll just go back here. This is what we're calling, or what census captures as low income cutoffs, or LICOs. And these are established using data from survey of household spending. And what this database basically does is it conveys the income level at which a family may be in a straitened or distressed circumstances, because they have to spend a greater proportion of their income on necessities than the average family of a similar size. So specifically, the threshold is defined as the income below which a family is likely to spend 20 percentage points or more of its income on food, shelter, and clothing than the average family. So we think this may be good information to have, as the cost of living does vary from one municipality to the other. In terms of, we've just looked at previous data on the average market rent. We know that varies across the county. Transportation costs can vary. In Owen Sound, there's bus service, and some of our other municipalities, we're starting to have a bit more bus service throughout Grey County, but overall the transportation costs do vary across the county as well. So that adds to everyone's expenses in terms of just living and just the necessities of life, essentially. So we just are starting to explore some of this data, but we wanted to share some of this because it does provide, again, some further insight in terms of those individuals are in residents in our communities that are living in distressed circumstances. So based on this is Owen Sound showing, and again, this is based on 2016 census data, just over 1,500 individuals in Owen Sound that are living in that distressed circumstance that we call it. In Hanover, you can see it's compared to others, it's a little bit less. So when you compare, actually, when you look at breakdown between low income households under 30,000 by municipality, and then the LICOs by municipality, you can see that there's a bit of difference. And what I will stress is that the top is households and the bottom is individuals, right? So in terms of numbers, so Owen Sound has the highest number of low-income households earning less than $30,000 per year, as well as the highest number of low-income cutoffs or individuals living in a distressed circumstance. Hanover, they have the 4th highest low-income households earning less than $30,000 per year, but the 7th highest low-income cutoffs by municipality. So what this likely may indicate is that Hanover, although there are households that are earning less than $30,000 per year, the amount of individuals spending a greater proportion of its income on necessities is less than other municipalities, meaning there are less individuals living in distress situations in Hanover in comparison to other municipalities. But as a percent of overall population, still has about 4.5% of the population living in a distress situation. And for Owen Sound, it's about 7%, based on this LICO data that we're calling it. So as noted, we're still digging into some of this information, and we may have more for the final report, but we just wanted to highlight some of the information to respond to some of the questions from the previous meeting, just to try to provide some insight into further breakdown in terms of the households that are earning less than $30,000 by municipality, just to give some further information to this task force, again, to help inform some of the recommendations and opportunities in the final report. Happy to take any questions if there are any.
Here we go. Thank you very much for that, Randy. I see Warden McQueen with his hand up.
Thank you, Mr. Chair. And to you, Randy, so that was based on 2016 stats. Does any staff have any feeling of where that has it stayed the same or has it changed? I know COVID-19 this year, I'm sure it's sort of probably turned it on its head because of what's happened in that part. But any thoughts there? Because we're 2020, that's 4 years ago data. And I just wondered if there, from what the county sees from social services and that type of thing.
Yeah, and based on survey data and other information that's being collected by our economic development folks and others, we know that that's increased. We know that individuals and households are struggling. They're, and so our guess is that there's more individuals that living in that low income cutoff or that distress situation as a result of the pandemic. And we don't have the exact numbers in terms of that, but based on some of the information that we've heard from families and individuals and businesses, we know that those numbers are likely have increased since 2016, and mostly as a result of the pandemic.
A follow-up question, Mr. Chair, if I may. So when things change like that and things get tougher, do you find then, so say it's young people can't afford to stay on their own, so then they end up moving home, or there's condensing of the low income moving into one unit or one house or that type of thing?
Yeah, I think the folks will look for all types of situations to try to address some of the challenges that they're experiencing. Whether, like you said, it's moving in with family members in order to try to reduce their overall cost of living, so I think there's probably a multitude of different things that people are doing in order to pay for, or to depending on their current situation. So Anne-Marie may have some further insight in terms of what we're seeing also from a housing perspective as well.
She sure does. I saw her with her hand up. Anne-Marie, you are muted, I believe.
Looks like she's off mute.
There you go.
Yeah. There. Oh.
But the volume's not working.
No.
Maybe what we can do is let Anne-Marie sort out her sound issue. And Barb, is there anything that you want to add to that? I don't want to put you on the spot, but maybe you do.
Okay, so is my mute, am I off? Okay.
I can hear you. It's a little, fuzzy, but okay. Go ahead.
I just wanted to mention that the CERB is actually providing an artificial floor for us. People are in receipt of that, and when that ends, we're expecting a huge influx to social assistance. We know people are not working. We know that when that benefit ends, they have to have some sort of income. So provincially, we're planning for that. And some of the strategies that we're using are centralizing of some of our services like intake, because local municipalities won't be able to handle it. So that's a little scary when we're thinking about how many people are going to require a basic allowance of just to meet their, their basic needs. And it really is very low compared to even the CERB. So when we get to that, we had expected it this fall, but fortunately the federal government extended the new program, but we're planning for spring. So what this might look like is a challenge. We're waiting for the numbers of people on EI or the CERB benefit for our region to be able to really understand what the impact looks like for us.
Thank you for that, Barb. I caught about 80% of what you said. It sounded like to an extent you were in that storm from yesterday. So Anne-Marie, let's check your sound now, but thank you, Barb.
Can you hear me now?
Yes.
Perfectly, yes.
Okay, good. I had to log in and out, but anyways. Yeah, and we've noted just people, as Randy said, moving in, like we may have a 1-bedroom apartment and we maybe have 3 or 4 people that are moving in and living into that, even though that's not specifically supposed to happen in social housing. It is happening because of a lack of anywhere else to go. Also, the numbers at the food bank have increased dramatically. So people that have never used a food bank before in their lives are reaching out and using food banks. So definitely since the beginning of COVID, we're certainly seeing an increase in people in need.
Thank you,
Mr. Chair?
Anne-Marie. Yeah, yes.
If I can just add, and I think our presenters this morning will have further comment on this, the assumption that people have family or have the family relationships that would allow them to be able to go back home is something that becomes an issue, I think, when people are struggling with their mental health or addiction. They may have burned those bridges. And just like Anne-Marie sees with some of the folks that we try to place into temporary housing, they're not able to go back to those places, and it makes it really, really difficult for them to find shelter.
Thank you. Any other task force members have anything else to add? Clark, did I see your hand up?
Yes, I was just going to note that the data is premised on private households, so it is, I think you can say, an underrepresentation because it doesn't capture those who are homeless, which is a growing population.
Right. Any other task force members with questions, or shall I move on? Looks like I'm moving on. I see Councillor O'Leary. Yeah.
Mr. Chair, are we going through this entire package? Like, I know we just talked about housing, but I printed off the entire thing and I had marked off, I think it's on page 3, recommendations and opportunities from October 2nd meeting with focus on Hanover. And I was kind of focused on number 2, that the heading is economic hub. Eliminated non-residential fees for those coming from outside the area. Other municipalities could consider doing the same. Does someone want to speak on that? I must have completely fallen asleep during that conversation.
Well, that's okay. I think you missed, were you away at the last meeting?
No, he was not feeling so good.
Right,
Yeah,
right.
Was it the last?
That's true.
That could have been it then.
That's okay. I don't know who wants to speak to that. Is Brian Teixeira with us?
No, he's not, Mr. Chair.
He is not. Okay. Perhaps I could speak to that then. For a number of years, Hanover had a sort of non-resident user fee for its particularly rec and park programs. Because there was a failure to reach an agreement with the neighbors with respect to contribution. Ultimately, a new council came in and decided that there was, the good neighbor policy to provide our services at par. I think that Hanover residents still have an opportunity to register a little bit earlier than non-residents, but the fee paid for anyone is exactly the same today. So that additional non-resident fee was removed in the last term of council.
So I just wanted to mention that, like, I am not a fan of getting rid of those fees because, you know, one of the biggest problems we have in Owen Sound is people are wanting to live, and I'll pick on Georgian Bluffs, but people are wanting to live in Georgian Bluffs because they'll pay $1,200 or $1,500 less for taxes, and they're 5 minutes from Owen Sound, and they can use everything that we have for free. So we've lost our non-resident contract that we had with Georgian Bluffs, but we still charge it. And I might be raining on everybody else's parade, but I want to go even further. Like, I'm looking at, and this is just me personally, but I'm looking at a parking fee for Harrison Park, Castle Beach, our rec center, our Bayshore Community Center, Castle Beach. There's 5 of them, and where we can charge non-residents $5 to park, and then if you're paying taxes in Owen Sound, then you don't have to pay to park because those parks belong to us. So I don't know if I'm going the opposite direction in my thinking with everyone else, but you know, we lose upwards of $700,000 at our Bayshore Community Center, and combined with the rec center, we lose $1 million. We can recover that $1 million by charging people to park from outside our area, and $1 million is a lot to turn your back on. So I don't know if anyone wants to comment on that, but just from reading that, looks like we're going in the opposite direction.
Right, Councillor O'Leary, my understanding, I'm sorry, am I interrupting someone?
Oh, no, I was just, after you're done, Mr. Chair, I was going to say I can speak a little bit to that because I did that report with Brian many years ago.
Go right ahead, please.
Oh, sure. So when we did that, we looked at the non-resident user survey, and we did a huge survey to residents and non-residents, and went through, that was my job, I went through one by one what those survey results said. And there were 2 really key findings that came out of it. One was that non-residents didn't look at themselves as non-residents because they came to Hanover to do all of their shopping. They came there for their services, their medical appointments, their schooling. So they saw themselves as giving back to the economy. And that was a really important piece, which was driven because of their participation in recreation. So they would come for a recreation program, and then they would go for dinner, they would shop, and they would do everything around that to keep their money in Hanover. So that was one key finding. And then the other finding was that because pricing in Hanover was really starting to increase, it was pushing some of our more vulnerable population out of Hanover to our neighboring communities, which then turned you from a resident to a non-resident because they could find cheaper housing in those neighboring municipalities. So they saw it as a kind of double whammy when they couldn't really take that hit financially. One, that they had to find cheaper residents elsewhere. And then because they were able to do that, they now had to pay a higher rate to participate in the recreation that they fully intended to do anyways. So those were the 2 big findings. And that's what went into that report to council that really helped make that decision to wipe out those non-resident user fees. And I just wanted you to have that information. Somewhere there's a report, and I know Brian will have it, but it was very detailed about why that decision was made, and it certainly wasn't taken lightly, but it was an important decision.
Yeah, I'd probably put myself, thank you very much for that, Savannah. I forgot that you were one of the key people involved with that report. Putting myself on a bit of a limb, I would say that we politicians failed the people in that process, to be honest. Because for years and years, there was a sort of very silent contribution agreement. So Hanover would provide statistics about non-residents that were using the services, and there was a contribution from the neighboring municipalities. In fact, the controversy came up when the neighboring municipalities no longer wished to contribute. So it went not just an increase, but went down to 0. And some of the local politicians, meaning Hanover politicians, said, well, geez, we have to stand up for the Hanover people. And so if you're not going to make that contribution, then we're going to add this non-resident user fee. And that went on for years and years and years. But as you're hearing from Savannah, that report spoke of volumes about what we needed to do when we actually reached out to the citizens, both resident and non-resident. The results that we got back led us to the decision that we made to remove the non-resident user fees. Are there any other members that want to add anything to this discussion or to anything coming from that recommendations and opportunities document? Okay, seeing none, then I'll move on to our presentations. We have 4 presenters, Alison Gauthier, Clark McFarland, Naomi Vaughn, and Kevin McNabb. And I'm assuming that they're going to be going in order and tag teaming, and we're going to hold our questions until the 4 presentations are completed. Correct, Heather?
That's correct, Mr. Chair. And I am going to share my screen for Alison's presentation.
Excellent. So Alison, welcome, and you have the floor.
Hi, thank you, Mr. Chair and fellow councillors. Can you hear me okay? Yes.
Yes.
Okay. Thumbs up.
Everyone can see the screen, the presentation?
Yeah.
Okay.
Okay, great. Well, thank you. And thank you for adapting the format today. The presenters all got together and talked about how intertwined mental health and addiction and all of our work is. And so holding questions till the end would allow us all to participate in the discussion, which we thought would be beneficial to this process.
And thank you very much for doing that in advance.
So yeah, I do want to thank you for inviting the Community Drug and Alcohol Strategy to participate in this consultation. And I see a lot of familiar faces on the screens today. My name is Alison. I coordinate the Community Drug and Alcohol Strategy. And as you're aware, Grey County has been a key supporter and stakeholder in the work of the drug strategy since it was established in 2009 under the name of the Graeber's Task Force on Crystal Meth. So we've grown since then to include over 20 partner organizations locally, and I'm also part of a network of coordinators across the province. So I'm really connected to other communities who are facing many of the same challenges that we're facing. So it's important to sort of have that link, and I can inform, part of this presentation will be informed by the trends that we're seeing across the province that impact our local response. I am going to focus my piece specifically on concerns and opportunities around substance use and addictions, because that is where my expertise lies in the community. I did provide 2 documents along with my slides. One was a data report on substance use trends, and the other was a 2-page document titled Principles of Harm Reduction. I trust that everyone received those and had a chance to look them over. Because of the time limitations today, I'm not going to go through the data and trends in detail, but I'm absolutely happy to answer any questions that you might have as you're reading through those documents. So I'm going to use the next 10 to 15 minutes. I've broken my presentation into 2 parts. So one is trends and concerns, and the other one is local assets and solutions. So Heather has displayed some key messages that I wanted to highlight before I jump into the bulk of the presentation. So when going back to council with recommendations, I trust that this first key message has already been taken to heart because you have invited the drug strategy to participate. But any kind of community plan around health and well-being must include a plan to minimize the harmful effects of licit and illicit drug use. And I make sure to include licit and illicit because I think it's important to recognize that alcohol and tobacco are two drugs that are legal and regulated, account for over 65% of the costs to healthcare justice and loss of productivity. So I know that there is a lot of focus on illicit drug use, as there should be, but I think that it's important to balance our resource flow and our interventions to also address regulated drugs as well. The foundation for such a plan should be rooted in principles of harm reduction. So harm reduction, when people think of harm reduction, we often think of needle exchange and naloxone and safe injection sites. But I guess I'm here to just talk about the fact that it's much more than that. It's a movement that's rooted in human rights and social justice. It looks at the quality of life, not necessarily the cessation of drug use as a criteria for successful interventions and policies. It looks at, how can we support people to reduce the harm related to their use and increase the individual's overall well-being. And sort of near the end of my 10 minutes, I will talk about the assets that we already have in our community and how we are strengthening how we understand and implement harm reduction interventions locally. So in terms of local concerns and trends, the first one I wanted to point out that I think will be quite apparent to everyone here today is the impact of the pandemic on people who use drugs and on overall well-being. But we know that addiction doesn't happen in a vacuum, and the pandemic has increased risk factors related to overall well-being, and in turn, risk factors related to problematic substance use. So some of those might be loneliness, stress, mental illness, housing instability, financial hardship, and most importantly, access to supports and social networks. Specifically around the social distancing measures, there has been an impact on people who use drugs and their ability to stay safe. Some of these measures have inadvertently reduced access to those social supports and opportunities for people to intervene because people are using alone. So I do want to talk about increasingly toxic illicit drug supply. We have lost 6 people from opioid-related death in Grey Bruce in the first half of 2020. Last year, we lost 16 people. And these aren't just people who are using opioids, but actually there's a trend towards polysubstance use. So folks who are using stimulants from the illicit market to manage withdrawal symptoms, or perhaps they're changing substances based on availability and affordability in the drug supply. So when we think about, folks who are overdosing, folks who are passing away from opioid-related death, it's not necessarily someone who just defines opioids as their drug of choice. It's anyone who may be accessing drugs from the illicit market. And during COVID, the illicit market is becoming increasingly toxic. Now, if you look at trends across the province, there was a 38% increase in deaths for if you look at the 15 weeks after the pandemic started compared to the 15 weeks before the pandemic started. And so we just need to be aware, again, that substance use and problematic substance use doesn't exist in a vacuum, and that all of these factors related to the pandemic have impacted people's overall health and well-being, which then impacts their ability to stay safe and to manage their substance use. We were, I heard that we, at the last meeting, you were talking about the ongoing housing affordability and challenges around housing affordability. And, you know, that housing stability is really an essential protective factor for overall health and well-being. So that goes along with folks who are managing or experiencing addiction. So, you know, not enough affordable housing to meet the demand, limited emergency shelters and housing supports really affects people's ability to either you know, get to a stable place where they're able to reach out for help or to maintain their recovery. And then I do just want to point out that this is a, you know, a long-standing concern, is that the mental health and addiction system is a fragmented and underfunded system compared to federal and provincial spending on physical health care. Mental health care or mental health services, especially in community-based settings, is very sort of underfunded if you look at it relatively. Now, I do want to acknowledge, with the creation of the Ontario Health Teams that is underway, and integration of mental health and addiction services in Grey and Bruce, we are seeing a more integrated model that is, I guess, sort of ongoing or underway. And we are seeing new funding announcements from the provincial government. So there absolutely is a trend in the right direction. But it is quite difficult to implement change and in sectors that are sort of at max capacity. So we always want to be advocating for, you know, more funding for mental health, but I don't think that that is a new concept to anyone around the table today. I also just want to point out that before I move on to sort of what is working well here, is that we are working within a framework of ineffective drug policy that criminalizes people who suffer from substance use disorder, and again perpetuates the discrimination against people who are using drugs. Recently, the Canadian Association of Chiefs of Police came out with a position paper in favor of decriminalizing simple possession of all drugs, and this goes on the evidence and the recommendations by health policy institutes. There's also a framework in the works in the States around providing a framework to legalize. We just know that the moralized view of addiction and substance use as a lifestyle choice has been detrimental to our ability to work with people and, you know, create a society and a system that works to support people who are using drugs, support them in their recovery and well-being. Now, all that being said, from what I see in our community is that there is a recognition of substance use and addiction as a public health issue. Recently, the Board of Health in Grey Bruce just passed a resolution in support of safe supply initiatives, which is an important harm reduction initiative as part of the spectrum of support. I also see in our community that agencies are embracing the harm reduction approaches in community settings. And so when I say harm reduction, I just want to be clear that, again, I'm not simply talking about, you know, needle exchange and naloxone distribution and safe injection sites, but really looking at the overall, I guess, framework or viewpoint that, for better or for worse, people are going to use drugs, and it's part of our world. And our job is to help minimize the harmful effects rather than condemn. And so that also looks at meeting people where they're at. So how do we work with people so that we can empower them to become the change agents for the well-being and the path that they see themselves on? And I talked earlier about the mental health and addiction system, just sort of from a funding lens, has been quite fragmented. But if you look locally, there are a lot of really important partnerships and integrations that are happening. And I won't list all of them right now, but I know that Clark will probably hit on a few. And Kevin as well. But for example, Grey Bruce Public Health is leading an opioid working group in Grey and Bruce, and they have created an electronic notification of opioid overdoses, a system that allows everyone, all the agencies that are part of the working group, to understand when overdoses happen in real time in the community and how to respond. CMHA is also working with police, to implement the MHART and ERT programs that works on the ground with police to intervene when there are situations where mental health and addiction are present. There are also addiction court support. So we have CMHA counselors embedded in the courts in Owen Sound and Walkerton. The RAM clinic, the Rapid Access Addiction Medicine Clinic, has been functioning in Owen Sound at Grey Bruce Health Services and is now also has an office and services at Hanover Hospital. So we see a lot of important and really key and strategic partnerships happening in the community that will allow folks who are needing mental health and addiction supports to have counselors meet them where they're at. So I think that's really an important trend, and it's a trend that's going in the right direction. Another key piece of harm reduction is engaging people who are using drugs in the creation of programs, policies, and initiatives. So thanks to the support of Grey County and Bruce County, the Community Drug and Alcohol Strategy has established a peer advisory committee. So this is a group of 12 people who have experience with addiction and who are available to consult with. So agencies who are thinking of changing or starting an initiative can come and consult with this group to better understand how to meet the needs of people who have used services and who have tried to navigate services and who have been successful. I probably am getting close to my 10 minutes, but I think that there is opportunity to build on some of these assets that we have in our community. A trend that I'm seeing across the province is expansion or the creation of what we call low barrier interventions. So these are interventions that are in community, they're easy for folks to access. So for example, one would be the safe supply, the one I mentioned earlier, where the Board of Health locally passed a resolution in support of it. But basically, it's a chance for people to not have to access the illicit market, but instead can work with a physician in a community-based setting to access a known dosage of a regulated medication that would be similar to what they would use in the illicit market. And studies have shown that folks who are able to sort of bypass the illicit market and get attached to a physician in a community-based setting, all sorts of positive health impacts occur when they're attached to a physician. Another big piece that I'm seeing across the province is the integration of harm reduction services into supportive housing and hotels. So across the province, you might be seeing emergency housing based in hotels. And so if there is an opportunity to meet people where they're at and provide some education and some support to folks where they are, then that's always an important way to do that. I think that I'm going to leave it there. I'm happy to answer questions at the end. I just want to thank Grey County and to all the partners who support the work of the drug strategy. It's something that we're really lucky to have locally. Other drug strategies do not have the stability that we have, just in terms of our support from councils and from community. And so it just allows us to work consistently together to achieve our goals. So thank you.
Clark, I believe you now have the floor. Thank you, Allison. Clark is with the Canadian Mental Health Association.
Thank you, Mr. Chair. My name is Clark McFarland. I'm the CEO of the Canadian Mental Health Association, Mental Health and Addiction Services. So just to add or build on what Allison has presented, I can give you a quick overview of the services we do provide, and then sort of some of the trends that our workers have been noticing, and then we'll get into some possible solutions or certainly avenues that I think we should consider. So just in terms of our service offering, we provide both mental health and addiction counseling to both youth and adults. We also have, as Allison mentioned, court support. We have court support for both individuals who are living with an addiction as well as mental illness. So these who are bumping into the justice system, and provide them with an opportunity for diversion from that and go into some treatment and avoid the justice system. We have a range of housing services. We have some residential services where we own a couple of homes where they are people's homes, and they are staffed. We also have outreach. We have owned some apartments which we are the landlords of. We have a rent supplement monies where we can supplement people's rents. And we are again working quite closely with Grey County in establishing a by names list position as well in that housing navigation piece. We also have social recreation programs, which are pretty important for building community and providing people with social contact. We run a couple of social enterprises, which allow people opportunities for employment. We have a catering business. We also run some gardens where we do employ gardeners, where that does feed into provide food for the catering services. And we are working on establishing a cafe. We provide mental health and addiction awareness programs as well. We are in the schools through fan clubs and Let's Talk programs. And as Allison also mentioned, we have reconfigured our urgent response team and now embedded the workers in each police station across Grey and Bruce. So the workers will be responding with police. The aim is to intercept and divert people who are in experienced mental health or addiction situation, and divert ideally from emerge if possible. So to decrease the pressure on the emergency service and provide people with a more appropriate service in a more timely fashion. We have also a 15-bed recovery home for men who are living with a substance use issue. We also have a peer support program where individuals who are living with mental illness or addiction have been trained in how to utilize their personal story to support people who are also entering into their own recovery. So we have quite a range of services, and see mental health and addictions from a number of angles. What our workers have been seeing, certainly in substance use, just to echo the themes that Allison has said, that over the past number of years, there has been an increase in use as well as increase in overdose. And also they're finding an increase in use of injection drugs as well. For housing, there is an increasing lack of housing, safe, affordable housing. I guess to give a sense of that, about 4 years ago, the wait list for a housing program was about 25, and it's currently 131. So just to put that in numeric terms. This lack often leads to people seeking out and invading others' homes as well, that our clients are. So our workers, housing workers, it's not uncommon for them to find upwards, 7 or 8 people in one apartment, especially as the weather begins to get cooler. So that is certainly a significant trend. There's also a large hidden homeless population, or sometimes called those who couch surf. So they may know people, they can find some shelter somewhere, but they actually have no fixed address. I guess just in terms of that availability, about 5 years ago, the average vacancy rate for the apartment program was 6 to 8%, and now it is 0. So we also have, I think, a growing issue of people aging in place. So certainly with our residential programs, they are growing older, and their needs are becoming more akin to long-term care than necessarily residential, and so we are faced with a double challenge there. Another trend is just a noticeable increase in the acuity of individuals coming into service. So there are being just increased complexity in terms of their mental illness and substance use. Also, there's workers are finding that there are more people being referred to service from outside of the area as well. So outside of Grey and Bruce. With regard to the youth, I guess there's a sort of a concerning trend that youth are seeing cannabis as being a lighter drug. It's not really an issue. It's just cannabis. So certainly a need for some more education there, and also similar, I guess, to the adult population, some multiple use of multiple drugs as well. Another theme as well is clients with no primary care. So that's sort of the snapshot of what people are seeing. I would like to echo Allison's bid for safe supply. I think it is the way things are going. It makes a lot of sense on a number of fronts. It is ensuring that people are consuming a drug that they know to be of medical grade, that won't kill them, and it sort of takes that market away from the illicit, money out of the illicit market. Anecdotal studies have certainly shown that there's a decrease in petty crime, as people don't need to commit any petty thefts and things to supply their drug habit. And so there's an opportunity each time to have a conversation around life choices and things. I think possibly very relevant for municipalities is urban planning, and there is work on what healthy communities, happy communities, and what one individual, Robin Mazunder, who's doing a PhD on this topic around how urban design impacts mental health, how you can actually have designed interventions where you need to create social spaces that support community and building of community. You know, homelessness is a reality. I don't think we're going to be creating the supply we need overnight. And you know, in listening to him, he speaks of avoiding design techniques where you have putting a third handrail in a park bench so that people can't use it as a bed, or putting spikes under so people won't sleep there. We may want to think about that a little differently. You know, there is a need for overnight shelter, I think, in the area, just that very, very temporary shelter. But I think I would certainly be interested in working with folks on this, is thinking about how we design our communities to support people's mental well-being and mental health. I think underlying all of it as well, I would be remiss not to put a plug in for just changing that attitudinal piece. I think for both mental health and addiction, possibly more for addiction, is to move away, certainly for addiction, move away from the moral definition and more to a health definition. And addiction is a health issue, and we need to view it as that. And for both, it's really, I think, important to just break down that barrier, that them and us barrier. It is people who are struggling with mental illness or addiction are in many ways no different than you and I. And we need to begin to move away from the them and us and see it just as us. And what can we do to help people overcome them? So that's my sermon for today. So.
Well, thank you very much, Clark. Naomi Vaughan with Grey Bruce Health Services. Naomi, you have the floor next.
Oh, thank you, Mr. Chairman. My name is Naomi Vaughan. I'm the Director of Mental Health and Addictions here at Grey Bruce Health Services. We have 45 inpatient beds. We have an off-site withdrawal management and 18 outpatient programs. So I'm going to go through each program a little bit and speak to some of the challenges within each section. So we have, as I mentioned, 45 acute mental health beds. That really should be enough for our area, but we found that we have such a large group of patients at our ALC that are finished their treatment but have no place to go. So at least half of 50% of those 45 beds have no housing. So some of them should be destined to long-term care homes, and they are more complex patients that are challenging for the long-term care homes. So they are not taking them. So they really essentially live on our inpatient unit. Some of them are dually diagnosed individuals that need an independent living situation. So they haven't really worked in the group home, so they need a home. And most of them have plans, but we might be even a year out till we can get a house built for these individuals with the community living sector. And then the rest are the seriously mentally ill patients that are very, very unwell, chronically unwell, possibly acquired brain injury from years of antipsychotic use. Those individuals as well have no housing options in Grey Bruce. So as somebody has also already mentioned, we've had an influx of people from outside the area. So when we have so we've had some homes, in particular, I'll say like Chesley Place, that has welcomed individuals from other areas with these very, very complex mental health and addiction issues. And then when that has broken down, they've ended up on our unit, and then we do not have the resources to house those individuals, and neither does our community partners. So that's been a bit of a challenge for us, is having these individuals come in from outlying areas. As well as has already been mentioned, is the level of violence, the acuity our rural hospitals and Owen Sound Hospital are finding it's quite intense. And so mental illness along with addictions, there has been quite a bit of violence. We've been upgrading all of our emerge departments to have one crisis room in each that is both safe and warmer and more welcoming for our individuals coming into the rural EDs. On our inpatient unit, we did decide to hire an additional security for the unit just because of, especially when someone's been using some of the substances that like crystal meth and the like that do cause a little more violence. So we had to up our security and really done a lot of extensive training in trauma and code white responses to ensure a response that's both helpful for the individual, the patient, but also for the keeps the staff safe. So we are challenged with the inpatient units around discharging to homelessness versus getting patients in from the rural sites. We appreciate being held in a hospital in Hanover is hard for Hanover Hospital, for the police forces there as well, who are often sitting security. On the other end, do we discharge someone, especially in winter, to homelessness? So I really like Clark's comment there about a shelter. I think it really is imperative for a short-term solution for our area, to have some more housing options. We do have 2 pediatric beds as well. We are not funded for those beds, but we acknowledge that there is a high volume of youth that are in need of mental health services, and it's really challenging for our families in Grey Bruce to be able to even visit their family member, their child in London, which is the tertiary that looks after our child and adolescent unit, our children, I should say. Ours is really essentially 2 beds with Keystone sitters doing some treatment, which we're very, very appreciative of, but a full-fledged mental health unit for child and adolescent would have psychology and certainly, a space that is suitable for children. And the 2 beds are always at occupancy, so we really, really need to find resources to have at least 4 beds. We have a withdrawal management that's funded for 12 beds, but we actually have 21, and so we are fairly full. Part of that is because we have a community addiction treatment service, which is a day program for 3 weeks for patients that are completed detoxing but needing a longer term program, are interested in having a program where they can attend daily. But because of our rural area, we do need to allow the individuals a place to live. So those additional beds at the withdrawal management are used so that people from Hanover and all the outlying areas can stay at the withdrawal management building to attend the 3-week program. We also have a rapid access addiction medicine clinics that we run out of Owen Sound. We also have the protocol in place in Wyerton, in Southampton, and I've just started up a clinic in Hanover, Cape Croker and Saugeen First Nations as well. What else can I say? We started a substance use strategy here at Grey Bruce Health Services and invited Hanover and South Bruce Grey. And this was really because what we saw was when we reviewed our data, we saw a high number of young men with substance use disorder on our mental health units. So the 18 to 24 age group is quite high, as was the 24 to 44. And the demographics we saw were male and single. So we thought we really wanted to do what we could to make sure these patients, when they're on the inpatient unit, are getting connected to community resources as quickly as possible. So we did fund a substance use worker who does attend to all the mental health and non-mental health units throughout the hospital. We also find if somebody comes in for surgery and they have a substance use disorder, being detoxed as they prepare for surgery has been a good opportunity really to talk about their substance use and see where they're at. And so having this worker available has been really helpful. As well, in our substance use strategy, we're really focusing, as has already been mentioned, on harm reduction. And we know throughout the hospital that we run typically a more medical model. So we've really done a lot of work to make sure our hospitals are using a harm reduction policy for our patients, and really trying to address the stigma in hospitals as well. What we've seen with our harm reduction, or with our substance use strategy, is that we've had a target of getting more patients to withdrawal management, so that we know that they're better served in the community for treatment, as opposed to in our emerge departments, in our inpatient units. So what we've seen with Hanover is that we've doubled. At one point, we've had 4.2% of people who are using Hanover Hospital for substance use using the emerge. We've doubled that, and in Owen Sound, we've also doubled from 10% to 20%. And in South Bruce Grey hospitals that are not part of our strategy, have chosen not to be, they still are at really 0% to get to withdrawal management. So we see that the substance use strategy has had great benefit of getting people to treatment when they are interested in treatment. We also have a variety of outpatient mental health programs. So we have case management and counseling programs throughout Grey Bruce. We have clinics in Hanover, both at the CMHA office and in the Hanover Hospital. We have counseling, we have case management, and we participate in partnership with CMHA with the drop-in clinics, which we've got throughout Owen Sound, Hanover, Meaford, Thornbury, Southampton, and Wyerton. And we, what else can I say? The sexual assault program has been really, volumes have been really increasing. We're actually now at 3 times our normal volumes for sexual assaults in Grey Bruce. So we have, it's a very, very lowly funded program. There's 3 staff, so, and we provide 24/7 care. So it's a bit 3 FTEs, I should say. So it's been a bit challenging. So we're still providing 24/7 coverage. We have had to go to our exec for some more funds just to cover this increased volume. So we stopped doing historical individual counseling and are only offering group counseling for historical sexual abuse, so that we are able to do the individual counseling for the recent assaults. Some areas that haven't been mentioned yet, I won't get into what you've already, I won't echo what's already been said by Allison and Clark, but I will say that we find that health and integration is greatly served by good transportation and recreation. I know we've talked quite a few years ago about giving a discount for the local bus for here in Owen Sound, so that our patients are able to travel, to get around to different services, to get around to visit friends, to do shopping. And we think that would be really an important direction, is to provide a discount for the bus pass, and as well a discount both in Hanover and here in Owen Sound for the Y for recreational services. To be able to access, swimming and skating and all those recreational activities really help with the health. It helps with having something else to do other than substance use for those. So those are 2 areas that I'd like to highlight. And then just finally, I would like to say that we're really concerned about the rising operational stress injuries in this area, and providing support to our police and fire and EMS services around the trauma that they're facing when dealing with the boots on the ground in our communities. That's all I have to say. Thank you.
Thank you very much, Naomi. I'm sure that there will be questions for you. I'm almost anxious to jump in, but I'll resist. Kevin, you have the floor next. This is Kevin McNabb, Grey County's Director of Paramedic Services. Kevin, you are muted. Yeah, there you go.
Morning, everyone. Can everyone see the screen okay?
Good morning. I can hear you perfectly now, yes.
Okay, thanks. Hey, just give you a perspective from paramedic services, what we're seeing in regards to mental health and addictions in the communities of Owen Sound and Hanover. So the first slide here, we look at calls for 3 years, 2017 to 2019, where the paramedic included the primary problem of what was found on the call. And if you could see here, behavioral psychiatric emergencies come in, I think, number 6 of those, about 4% of our calls. Overdose does not come into this, it would be under the others. One thing to take note is probably about 10% of our people we don't transport to the hospital. It mentions there about transported by police. The patients generally are not transported by police, but we do rely upon them heavily for our scene safety. So they are an intricate part of our team when we're out there on the scene of these calls. In Owen Sound, the behavioral psychiatric primary problem card is number 4 out of our number of calls from 2017 to 2019, just over 11,000 calls we looked at. And again, the non-transport's roughly about 9.6%, and police are involved in custody very rarely, but they do play a significant role. I would say the majority of these calls, they're on the scene with us. So just looking at the last 3-year trends, I wanted to kind of give an update of the number of calls that we're seeing, and this 2020 will be up till the middle of October. Like just from my look at the analysis, I'm not saying there isn't a spike in the community. We haven't seen a spike through COVID in around alcohol and drug overdoses, as well as behavioral emergencies. We did notice in 2019, and particularly in the first half of 2019, we were on a trajectory for opioid calls that would be significantly higher than we've seen before in the past. But they did taper off towards the end of the year, which was we were pleasantly happy to see. But as you can see here, these calls are happening in these areas. Opioid overdoses, we've been tracking them since May of 2017. At one time, we used to just track drug and alcohol overdoses, but we were able to break them out now. And as opioid specific, it helps us do some of the work that we do in the background. So you can see from these calls, they are happening in those areas. They do make up a number of calls that we respond to. The one thing around drug and alcohol and opioid overdoses, or just in overdoses in general, this doesn't take into account where the primary problem may be a physical injury from an assault. So those types of things, particularly around the drug and alcohol, if there's a domestic or some sort of fight, we wouldn't be picking that up on this as well if there's any ramifications from drug and alcohol in that perspective. So from our initiatives and how we respond to this, we take an active role in the Drug and Alcohol Task Force, as well as the opioid working group. Through there, one thing that we've set up is as soon as there's an opioid overdose happen in the community, it creates an automatic alert to public health, who monitors those alerts, as well as our supervisors and our managers and myself, that we're looking for any more than 2 overdoses in 24 hours or a string of events over a period of 5 to 7 days. And if this is noticed, we will get the group together. Particularly, it starts out with public health and ourselves, and the messaging goes out from there to let people know what's happening in the community, what we're seeing. We look for trends of what is being seen on these calls, and be able to share this information out that something's changed in the community. We work with the Canadian Mental Health Association Urgent Response Team. We're very happy that they're able to participate in this with us. If there's a behavioral or psychiatric emergency, similar to what the fire department does on a cardiac arrest, they notify this team and they come out with us on these calls before we arrive at scene, with the goal of them being allowed or being there at the same time or shortly thereafter to offer assistance on the scene. Another initiative is referrals. We've looked at ways of referring people to supports in the community. It started back in 2009 where we refer people to Lynn Home Care. But in the last year, 1 to 2 years, we've been looking at other ways. We do have social economic support through 211 Community Connections. It's not your traditional 211. We have a way of referring to the back room where they have poverty screeners and are able to offer social economic support for these people. And just new this year for addictions, we've been able to get a referral directly to the RAM clinic. So we've been very fortunate to be able to do that, working with our partners. We are through COVID, and we've been working on this for a while, is looking at high use callers. We're able to look through our 911 data, and it is set up now that weekly we will dump these calls into our community medical record, and we'll look at patients that are high users of 911 with the goal is we have modified workers and also we have a group called Vulnerable Patient Navigators who are on a first response unit that will be following up with these patients, and they are following up with them now to offer referrals again to the RAM clinic, 211, and also to Lynn Home Care. Some future initiatives with modernization and new models of care. The government's looking at palliative care as well as mental health in the community. One of the options we're looking at right now is to move ahead with a new model that would help us or have us work more with the Canadian Mental Health Urgent Response Team, where we would send a single person paramedic and also an urgent response member, which would allow us to be able to spend more time on the scene with that person and ensure that they get the resources that they require. Particularly, we'd be there for the medical side of things, and the urgent response team member would be supporting their mental health needs. And another one we're close to implementing is Naloxone Distribution. We're seeing more and more Naloxone utilized in the community, which is a really good thing. The problem is at 2 a.m, they have no way to replenish that supply. So our goal would be able to leave that Naloxone with the person or people that are still on the scene and be able to ensure the safety of other members that might be there as well. That's all I have for that presentation. Thanks.
Thank you, Kevin. Very interesting. Now it's our turn. I'm sure that you've all been taking notes and listening carefully. Task force members, are there any questions of our presenters? I've got questions if you want me to get started.
I have some too at some point.
Well, Kim, why don't we start with yours, and it'll give the committee members a chance to get their notes together.
Okay, thanks. First of all, I don't know, maybe Clark or Naomi, any of you, what is there a percent of the population in any population that you feel is suffering from substance use disorder?
I'd be able to respond in terms of mental illness, but in terms of substance use disorder, Allison, would you have a number on that?
It's a tricky one to pin down because often it's an illegal behavior. And so to keep stats on illegal behavior there are some self-report surveys that are administered provincially, as well as through StatsCan. And they look at it by substance.
Okay.
So I do have some stats around what percent of the population would go into the category of regular heavy drinking. So drinking above the low risk guidelines. But in terms of illicit use and when it goes from sort of recreational to problematic, it's a really tough thing to pin down.
Okay. Clark, what about the mental health side of things?
Well, typically the number used is 1 in 5 Canadians will experience a mental illness in the this year. So on a yearly basis, 1 in 5 will have that.
Now, each of you at some point talked about people coming here from other places and seeking support, which then, I don't know, can lead people to be somewhat reluctant to make significant investments into more treatment because you feel like it becomes a little bit of that if you build it, they will come situation. How do you respond
And Kim, if I can
to
add
that concern?
I had a similar question as well. Whoever's answering, can you also answer what exactly is fueling that influx?
Yeah.
Well, I'll take a stab at those. And Marie may have a point on this. Certainly, for the housing issue, it's kind of a relative scale, because someone who's on a wait list in Toronto who's being told, well, you'll have something in 11 years, looks north. They say, wow, that wait looks pretty short, so I'll roll the dice and go up. So that I think is a piece of it. I think if you build it, they will come. That is a concern, and that issue has arisen with the safe supply, implementing safe supply. There is a committee at our provincial level at CMHA looking at that, and at a provincial level we are working with the chiefs of police and the province to look at how we can roll out safe supply in a logical way, so that if the larger centers get it first, I think there's a little more reassurance in the smaller centers that if they build it, then people won't necessarily be coming because there's access closer to home for those. So I think there are ways we can address that. I think it will take a coordinated effort across, at a provincial level. So I use safe supply as an example, but I think we could replicate that in other ways. That the shelter piece is a challenge for us in a rural area, where certainly Owen Sound and Hanover having larger densities and larger populations a little easier, but we have that issue across the area. So how do we create a sort of decentralized shelter system? I don't know, but I think it's worth tackling that and trying to figure it out.
Thank you.
Thank you, Kim. I have some questions, but I'm happy to take questions from other task force members.
Mr. Chair, it's Brian. I might have 15 or 20 minutes to talk there, if that's okay.
How about 30 seconds?
I don't even know where to start. I guess the biggest one for me is because I'm way more involved than I need to be with the Owen Sound hotspot. We started with a neighborhood meeting that involved both Allison Govier and Clark were there. Maybe one of you or both of you can tell me how involved you've been with the hotspot. What have you done in terms of help?
I haven't been directly involved in that issue. The larger, I guess at a larger, higher level, just trying to move forward. Again, that issue of, I think safe supply becomes a response in that situation, and that those same issues come up in terms of trying to implement that. That if you build it, they will come, and so we need to address the larger centers, doing it first before we really get some buy-in from other services, police, etc. And then there are some more local issues in terms of physicians having wanting to see gaps in service filled prior to moving on to safe supply, such as having greater access to case management for them. Those, I'm talking about physicians who are currently involved in addiction medicine, who would be open to and willing to venture into safe supply.
So Clark, just on the, like you talk a lot about safe supply. Let's talk about the Methadone Clinic in Owen Sound. Tell me what that does for Owen Sound.
So maybe Naomi could speak to that. I believe that's the.
Sure. Yeah. We don't look after the Methadone Clinic. We look after the Suboxone, but I'm happy to say we feel Suboxone is a healthier option for people, and it does help with the cravings so that people can get off of the opioid once they've chosen to stop using opioids. Then they can come to our clinic, which is Rapid Access Addiction Medicine Clinic, and we see them and provide counseling, which is, I know, a little different than the Methadone Clinic downtown, where it seems to be an ongoing. I can't really speak, but I know from before when I looked into it, I know that patients are on methadone for years. Our goal with Suboxone is that we see them, daily and a couple times a week, and we keep them connected to New Directions once they're able to take them. Then we transition them, and then our physicians stay involved. But it is a very helpful way to help people get off of the opioids.
Okay. So
Yeah, I can.
Okay, sorry, go ahead.
I'll just speak a little bit to the Methadone Clinic. My understanding is that it is a provincially, it's a provincial body that is set up in our community, that there is a regional coordinator who works not just in Owen Sound, but has, I'm not sure how large her region is or how many clinics she looks after, and that the funding model does not allow for wraparound care like the RAM clinic does with the Suboxone, and that it's actually becoming an outdated model, and that RAM clinics really are meant to be the direction that policymakers want to see the opioid antagonist therapy going. This is just my personal opinion, is that the care provided at the Methadone Clinic just does not fulfill the client-centered wraparound model that should be available to people who are accessing methadone.
I think the longer term as well, certainly I think one of the functions of the RAM clinic as well is to move addiction medicine more into the mainstream primary care. Allison had mentioned drugs are part of life now. They are with us. Cannabis is being brought online as legal. And I think it's really important that people have access through their primary care provider for that, and that primary care providers be educated around what to look for, and then how to treat and how to intervene. So that really is, I think, where we need to get to in terms of that dispersion of service and resource.
And if I can just add to that, that's right, Clark. That is why I don't say we have a RAM clinic in Wyerton or Southampton, because we have already provided the physicians there with training, and we've embedded it into primary care. So if a patient goes to the emergency department in Southampton or Wyerton, they are started on Suboxone, and then those physicians are following them. And so that's really our goal with RAM, is that we provide the education, the training, we start the clinics up, and then we really back away. So that's our hope also with Hanover, is that we'll be there just to get things going, and then the primary care practitioners in that area will take it over.
So I think I want to talk about perception. Like, I'm not sure how we excuse me. I'm not sure how we measure what it is we're doing. I would say if you ever polled the city of Owen Sound, like residents, 80% would probably tell you that the Methadone Clinic is the worst thing that ever happened to Owen Sound. That's the perception. This neighborhood where the hot spot is, they have a blog of 14 people, and they're just, everybody talks every day and every night because they're all one big unhappy family. And that group will tell you that they've completely been failed by mental health, and they just don't feel like the help is there. You know, like when an elderly person has to put a cowbell on her front door so that if somebody's kicking her front door in, at least she knows they're in the house. I just don't know how we can measure, and I'm not trying to be personal here. I'm just saying that people, like, we have so many things going on and no way of measuring what exactly we're doing. And I feel like as a decision maker, you know, in sound, it should be council that should be doing something about something, but I don't even know where to start. Last week I met with Dr. Ara, and I talked to him about a rehabilitation center. Is that something that we can sound? He's setting up a meeting with Ian Wright this week with me. I had a sit down meeting with our MPP on Thursday night, and I said, you know, Bill, somebody's got to do something about our opioid crisis, because I just feel like all we do is talk about it. It's like affordable housing. We've been talking about affordable housing for forever now and haven't done anything about it. But all I hear is like outreach, harm reduction, advisory committees, collaboration. This is just the way I feel, but I told Dr. Ara, the most overused word I hear on council is collaboration. Everybody works together. We've got all these different centers, but what do we do? So Allison, you mentioned death numbers at 6 in the first half of 2020 and 16 total last year. I thought the total was 15 last year, but the number I have right now is that we've lost 19 with 6 weeks to go in 2020. So I said to Bill Walker, you know, we spend all this money on COVID, and we're so proud that in Grey and Bruce counties, we have 0 deaths with the pandemic. But yet our opioid deaths have gone from 15 to 19 with 6 weeks to go in 2020. What are we doing about these deaths other than just talking about it? Because I don't think, as much help as there is out there, why are the numbers going out, and what are we doing, or what do we have that we can measure something decisive of what we're doing about our problem? I know that's a lot, but I'm trying to just make you understand how I feel.
Yeah, no, I appreciate that, Brian. I'd like to maybe have a discussion about where the numbers are. You're getting your numbers. I'm just looking at coroner's numbers that have been released. And so maybe you have access to numbers that I don't have access to. I think that this task force and this conversation is a good place to start in terms of really getting down to the bottom of how can we work together to do things that make a big impact right now. But trying to answer and address your question in a fulsome way, Brian, right now, I don't feel is really a fair venue to do that. I am aware of wraparound community-based models that we can implement in our community. It requires resources, and we can apply for those resources, and we can work together. And I'm happy to continue this conversation with any members of council. There are really good models to look at.
I get
Mark,
that.
do you want to add anything?
Sorry, Brian, go ahead and I will add after him.
Well, I was just going to say, it just seems like I'm not looking for you to tell me anything definitive today. That's not really what I'm after. I'm just trying to get the message out there, because it's no different talking to Bill Walker. You know, he said, Brian, you're talking about a rehabilitation center. Like if I ever got that in Grey County, every MPP in Ontario would want that. Like why would Owen Sound get that and not? But you know, it's a complete deflection. And I said, okay, then at least go down there and rattle some chains and find out, like, at least do something. Like our police chief will tell you that sometimes they arrest the same person twice in the same night.
Mhm.
Like, how does that happen, or what are we doing? Can we not? And these addicts, all we do, you know what we do with them? We give them a criminal record, so that if there's a half-assed chance of them ever coming out of it, there they are with their criminal record, and nobody wants anything to do with someone with a criminal record.
Mhm.
You know, I don't know whether we need a judge to face these people in court and say, okay, this is the way it's going to be. You're going to jail for 2 years, or you're going to rehab for 1 year, so that we know that that person is going to get rehab for 1 year without just looking someone in the eye and say, I'm all better now, I'm leaving, and make them get their rehab. I don't know if that's an option, but for me, all I hear about is like safe supply. We want to give them, like, for someone that doesn't understand it, I'm just thinking, like, what are we doing? Like, what about putting them in a facility and rehabbing them where I mean, it's incarceration. Like, it's a bad word, but get them in there so that you know that they're at least going to come clean within 6 months, and another 6 months of rehab, so that they have some kind of chance to contribute to society. Anyway, I think I've said.
So a number of points, I guess, and I think we certainly share a frustration on a number of levels. It is a complex issue. One of the confounding variables is that people do have choice, and we can't we can't take that away from them. I think if the police chief was here, there are limits in terms of I can understand that impulse of let's just take them and put them in the rehab, but again, that's beyond us. There would have to be some breach or some premise to do that, and even if you do that, it isn't necessarily going to address the underlying issues that are at play as well. So, not that it's a satisfying answer, but I think jumping to in terms of the measure as well, I think that starts with defining a goal clearly. So, what is our short-term and what is our long-term goal, and what can we measure in that? I think we'd have to work on defining that if we wanted to get the brass tacks and measure. So the safe supply issue is I think it is a needed response, and there's going to be no one silver bullet that would take care of everything. Even people, relapse is a reality as well. So people can go through a process, come out, and then relapse again and again. And so it's that there are. I think we have to acknowledge that as well. So it's. I just wouldn't want people to think that if we build a recovery center or a treatment facility, put them all in there, process them through, and then it's solved. That's I don't think a realistic expectation either.
Well, final word, Mr. Chair. I do feel bad for you people, because I think what you really need is to see more results, and it just seems to me from the outside looking in that everybody is just coping. We're just coping, but we're not doing anything definitive. And it's people like council. Like, council needs to make some decisions on something, but somebody's got to tell us what we need to do.
Okay, thank you, Brian. And Kim, I did see your hand. I'm going to get to you. I'm looking to shift the conversation just a little bit, if I could. Naomi, I'm glad that you're back in your seat, because one thing that you mentioned in your presentation was a stat around sexual assault, and the volume being 3 times as high as usual. Like, Wow. So maybe you can tell us, what's behind that. And as well, I think it might be appropriate for you, a question around, again, at the Board of Health, we heard about the statistical tie between adult people that are dealing with drug addiction and childhood trauma. There seems to be a strong correlation there. So you spoke a little bit about us addressing children's mental health, but it strikes me that, if you can get it at the childhood trauma piece, we might have less to deal with in the adult section. So those two pieces I'm hoping you'll address. But before you do, I'll give you a chance to come up with your response. Kim, I want to allow you because I did see your hand up, so you should go before me.
Oh, not at all. It was just a thought, and a kind of building on what Councillor O'Leary is saying. We do have the opportunity at council to advocate, to have those discussions, as Brian has started to do. But is there an ask? Is there something on that we could go forward to the province and say, we really need this? Is it to enhance the funding that Naomi's pointed out she could really use? Or is it, we've already started down the road of supportive housing? Is it more of that? And like, pick a number that would be useful. I just think if we could, get our arms around an outcome, as Brian says, and determine what it's going to take to make that happen, it would be a step that we could point to and build from. But is there agreement about what that would be?
Well, I'll just speak for me. I think what Chairman Hicks has pointed out is, I do, even though I'm in the adult sector for the most part, I do feel that our work needs to begin with our children, and which is why I spoke to the recreational services being strengthened so that children have access to programming that will help with their mental health and their physical health. I do think as well that we have a lot of children that come into these 2 beds that we have that have behavioral issues, that have not what I would say is a true mental illness. They've got trauma, they've got behavioral issues, their families aren't coping, their families need help. Their families need help now. And so even though the hospital is not always the best place that this happens, this is what happens when a family's in crisis, right? And they end up in a, and I would like to think that we've had the resources here then to connect them back. So I would like us to have 4 beds. Sending kids to London isn't helpful. Our community is here. Our families need help here. So to have the 4 beds, we get the children in, we get Keystone involved, we get them hooked up to community resources, and they're back in their home, and we're not disrupting the families. The trauma that the parents are facing, that spills onto the children. So having that option of trauma therapy, which is the OSI clinic, the operational stress injury clinic that we've long talked about, and really just trying to strengthen families, I think is really critical. But I also have to say housing. We cannot do any of our work as long as our emerged departments are all struggling with this volume. We need to get these beds opened up. We don't need more beds. We really don't need more inpatient mental health beds. We need our patients to get out and back into community where they belong, back into long-term care. So I know there's talk about the behavioral support unit. Didn't talk about it, but it's been a few years. If we could open that, we could open up the beds and then get our community into our community resources, working with the hospital to support the individuals when they're out of hospital.
Anything to add to that, Clark?
Thank you.
I would underscore the housing piece from my perspective. It is one of those fundamental determinants. You need safe, affordable housing. In addition to the housing, though, you do need the supports to surround it, to ensure that people succeed in turning the house into a home. But I think that is one of the underlying pieces we need to address. It certainly impacts the hospital. It impacts the individuals who are in need. So.
And Allison, anything to add?
Yeah, I would add to that that outside of our organizations and agencies and institutions, there are a whole subpopulation of people who are just not going to make the choice to access an agency. They don't feel that they feel comfortable or safe there, or it's just not something they've identified as a priority for them. And so there's these people. I think that it would correspond to Councillor O'Leary, what you're talking about, the hotspots, is that people who might need some community support but aren't going to go into an institution or an agency and then either end up with police or at the ER. And so moving away from just thinking about bricks and mortar, but also thinking about like, how do we build outreach resources in our community? And that's what I heard from the community group at that initial meeting, is that they want to see people on the ground who are accessible to folks who need help in the moment. And so, like, if you look at Peterborough, they're just about to implement a partnership between the police and addiction services, where it's a peer-to-peer outreach program. And so you have people building community in community with one another. And they've received, I think, over $1 million to implement that in Peterborough. So I think that outside of our agencies and institutions, or in collaboration with our agencies and institutions, there's a lot of work that can be done in community.
Anne, I see your hand. Or Anne-Marie, I should say. It seems that you're still muted despite the fact that you may have turned it off. No. Maybe we'll let you sort that out. Barb Feedy, was there anything that you wanted to add to this?
Hi, so I've put my headset on. I hope that's a little better. Excellent.
I can hear you perfectly, yeah.
Oh, I'm so glad. Okay, I just wanted to bring to your attention that we just launched the community safety and wellbeing the plan. And I think that's the measurement piece, Brian, that you're looking for. We have gone through a significant survey. We are gathering the data now. We will have an addendum to the plan, which will include all kinds of data that will help us to determine, where we're sitting and how do we know what we're doing is actually working. All these efforts, all this collaboration, that's a good thing. It's not a bad thing, but it is hard to understand that there's any impact. So we are moving towards having that available by we're hoping the end of December 31st for that report. The fact that we know that if we could put some dollars early into the interventions, Naomi mentioned it, helping families before they become a crisis. I think there's work happening at the provincial tables. Why I would say that is that right now, social assistants, both OW and ODSP, are going through modernization processes, and the employment piece is being extracted. Okay, so we're looking now at pre-employment programs that will be delivered by the municipalities for social assistance. Pre-employment, that means mental health, that means paying for the bus tickets, that means how do we get someone out of their house when they're isolated? How do we ensure that people are connected? What are they doing to be ready to take skills and to participate in enhancement programs, pre-employment? So I don't have a definition yet. It's coming. That's called life stabilization, and we are going there in early 2021. So more to come on this, but I thought I'd take that opportunity to provide that to you.
Thank you. I don't see Anne-Marie back yet, but Naomi, can I circle back to you again just on that 300% increase in the demand for sexual assault counseling? I mean, that's wow and alarming. I do see Anne-Marie now. But can you just maybe speak a little bit about, is it more occurrences or is it just more victims willing to come forward and say, I need help?
Yeah, I think it's a little bit difficult to suss that out, right? But from provincially wide, the numbers are all up since COVID. So I think there's, a relationship between, especially around the domestic violence piece, but also the sexual assault piece. We've had a number of situations that are unusual around really the date rape drugs out near the Sobel area. So it might be tied to the substance use piece as well. But those numbers were really quite high for a couple of weeks. So it was very, very concerning. Yeah, but certainly provincially wide numbers are higher.
Thank you, Naomi. Anne-Marie, you're back with us. Let's try again.
Can you hear me now?
Perfectly, yes.
Perfect. Sorry about that. I'm not sure why it's fading out. I just wanted to reiterate what Clark said about supports. We do have affordable housing in our own housing, but we know we've implemented a lot of outreach supports. And we do have a lot of people that without the supports, they would not be able to maintain their housing with us. So supports are very important. Affordable housing alone is not the answer. We need both. You need both. And I recognize we need affordable housing, but supports are just equally as important. We do have a number of people that refuse supports that live with us too. And so unfortunately, sometimes it gets to a point where we have to terminate their tenancy. And that's the last thing we want to do. But sometimes for various reasons, that is the only way that we can go. So supports are definitely a large piece of the puzzle.
Thank you. I'm going to turn back to task force members. Is there anyone else out there that I know we want to try to wrap up by 11:30? Warden McQueen, I see your hand.
So a question more general in the sense of I was listening to a CBC program last year, and I think I mentioned it to some other staff at the county, but it was mentioning that in Canada, over 1 million Canadians don't have a bank account. So how do you, and I know at the county, I guess there's ways of doing it, but how do you deal with individuals that, I guess, I think one individual said about they don't have a fixed address, so I guess you can't really, so can anybody explain the dynamics around how do you get money or how do you help people? One, if they don't have a bank account, they don't have an address, how do you track people down, or how do you help people in the sense of following up with people other than if they come to you, I guess, and because probably a lot of them maybe don't have a cell phone because of financial circumstances or whatever. But how do we follow up with people, say for helping or for following up and say, like, any thoughts on that, anyone? Or
sounds like a Barb Feedy question, Paul.
I was just going to jump in there. Thank you. So we do have ways and means to help those folks, actually, Mr. Warden. We have in the past used our own address for at 595 9th Ave East here for anyone who is vulnerable and not as stable. But we now have a lot more opportunity to use technology. And I think I was trying quickly to find the numbers, but I know we've provided at least 120 laptops, refurbished laptops, to folks who are on social assistance for learning, distance learning, for training, and for connectivity, for exactly what Naomi and Clark and Allison have been speaking to, as well as Kevin, where people just need contact and they're isolated. So we are also providing phones for, and we have this system called Connect to Text, where people can just text their worker. We have modernization underway across the province. We think we're isolated. Think of the northern and very rural communities that have smaller populations than certainly we do. And so, to be honest, I think we're serving them better than we've ever served before, because we used to ensure that people had to come in to see their workers. We don't have to do that anymore. We have a reloadable payment card. It's like carrying a debit card around. And if people lose that card, we can replace that card. So we are working with banks, we're working with policy, and certainly.
Looks like we lost Bart.
Oh, darn, sorry.
No, you're, I can hear you now.
Okay, so just lots of other options with technology that allow us to keep and maintain contact. Contact is that key component for us to help someone.
I think it's also part of the hard work of on the ground outreach as well. You know, finding people, reaching out, establishing a connection, a rapport, and seeing where that can take you as well in terms of service.
Well, thank you for all that information. I'm what would you say, impressed, or I'm encouraged, I guess, from what you're saying, Barb, about how you're reaching out to people, because you can't even hardly find a payphone anymore. If you know, if somebody had a quarter, and you know, because our whole society has changed with technology and that type of thing. So I'm happy to hear that. Thank you.
Kevin McNabb, I see you're waving your hand.
Yeah, I'm just thinking as we sit here, like even myself, I have these stats like of the number of calls, the number of incidents, but I really don't know the number of people that we're talking about. Is it 10 in Hanover and 50 in Owen Sound? It'd be nice to actually have somehow to identify those people. And, you know, when you think about health links, how we would wrap services around people that required this for their medical conditions. It's almost like trying to find, you know, whether they're high use callers, we identify through police and paramedic services and the use of ER. And then from there, you know, be able to target those individuals to get them the help. They may already be getting the help, they may not. But I think that like right now, we're kind of, in our perspective, we're totally reactionary. You call, we'll help try to sort you out the best of our ability. You know, then we try to connect you because you've called, you know, multiple times. But it'd be nice to start using that data as a group and be able to offer those resources. That's kind of what I would like to put out there.
Kevin, I'd love to talk to you more about that, because that's the model that they went with, and or that's the foundational research that drove the new initiative in Peterborough, where they're looking at those people who are frequent users of EMS and other services, and they created basically like a wraparound, like a team of supports to help establish relationships with those folks. And it's not necessarily with the end goal of getting them into a service, but really just to start with the relationship building, peer-to-peer relationship building. So I think you're on something there.
Can I ask, is this like the situation table idea? Would it be the same?
What do you mean by that? I don't know the situation table.
I think Anne Marie and Barb, you're familiar with that model. Halton has a very well-developed situation table, and that was kind of the precursor to the community safety and well-being.
Yeah.
That we utilize. It's Naomi. I was just pointing out, we do our situation table is used, I think, quite a bit. I know I have staff that attend to it. We did a review of our high users in all the emerged departments and in PA, and we did identify the top users and applied for a ministry grant one year and provided this wraparound service to them. And we have really great data that came out of it. It went really well, but we weren't funded for ongoing funding. So that was unfortunate.
What kind of money were you talking about, Naomi? Do you know?
All we did is we hired one nurse and one social worker. So it was probably, you know, somewhere.
Two.
Like it was two staff. So it was probably, you know, 250, 300,000, somewhere there with travel and bought a lot of cards. They gave everybody a tablet, all the people on this list, either a phone or a tablet, and we did quite a good review. I can always send it as well of the program.
I think that would be useful.
I can send you it. It was a now, but it was, it really worked. We just did it from all the emerged departments in Grey Bruce and Owen Sound.
Thank you. Councillors Desai and Milne are unusually quiet. Anything from you folks?
Thank you, Mr. Chair. It's I mean, great presentations again, and some very interesting, I guess, points that were made. I do sit on the Community Drug and Alcohol Strategy group with Alison and Clark, and so yeah, a lot of this information wasn't as new to me, if you will, but it's, you know, I mean, often we've talked about the opioid crisis in our communities, so it's a little, quite a bit to digest almost, and so yeah, it's heartening as well to see that there is something being done about it, and there is dedicated people and groups that are looking at these issues. And I think it eventually will come down to at a county and a municipal and government level how we want to fund these activities. And you know, so yeah, I think that's a conversation that I would be looking forward to as well. But again, like I said, it's quite a bit of information to digest, so which is why I've been quiet. I don't know about Councillor Milne. I can't speak for him.
Well, that's good. Thank you, Councillor Desai, for admitting that you don't speak for me. I wouldn't want that to happen, that's for sure. I guess my thoughts are, to this point, is a comment that Councillor Leary alluded to when he had a meeting with our local MPP last night, and it's an issue that has troubled me for a number of years now, and is that we can only do so much here locally, and we are doing a lot, but we can only do so much if we don't have the support of the higher levels of government. And it frustrates me when I hear Councillor O'Leary saying that the MPP is deflecting the issue, saying that, well, if we gave this to Owen Sound, everybody in Ontario would want it. Well, if everybody in Ontario wants it, then why aren't you doing it? Because clearly it's a needed help. And Alison rather alluded to it when she said that mental health is badly underfunded in relation to other jurisdictions. Then why aren't we funding it to that level that's needed? I think if we had better levels of funding from the upper tiers of government, if they deemed it a priority, they would fund it. So it frustrates me to hear that the local MPP is deflecting the issue. And I'm not being critical of this particular government. This has gone on for many years. So I don't know. I don't know why I'm particularly quiet today, other than I had some internet issues at the start, which I was not quiet when I was talking to my computer. But in any case, I do appreciate the discussion here this morning. Thank you.
Yes, thank you, Councillor Milne, and I certainly appreciate your Mike Holmes look today. It's very fashionable. Brian.
Mr. Chair, if I could, I just wanted it good to hear from you, Councillor Milne. Just to clarify, Bill did deflect we were talking about the rehabilitation center, and that's what he was deflecting. But he, you know, we did come to an agreement that he was going to rattle some chains on in terms of doing something. But just from what Brian just said, you know, part of the problem is that we are so selfish as a society. We don't go after funding for all the right things. We go after the things that the uppity ups, if I could use that term, we don't go after things for the most vulnerable, and I think that's a problem too, and that we can put on ourselves.
Okay, well, feel we need to wrap. We are past the hour that we said we would conclude. Unless there are other remarks to be made, and I don't see anybody with their hand waving, I want to thank our presenters, Allison, Clark, Naomi, and Kevin. This was a fabulous discussion. I feel like as a member of this committee, I'm getting an education into our community that isn't offered anywhere else. Fabulous discussion, really great information. I hope that some tangible things will come out of it in terms of recommendations and in our action plan. But you've certainly contributed a great deal to our ongoing, I guess, investigation. And I want to thank all of you for your time. And I learned a new term today, situation table. So maybe I should have known that already. I used to be involved in social services in my day, but situation table is a new term for me today. Again, thank you to everyone, and have a great day. Cheers.
Thanks, everyone.
Oh, we need a motion to adjourn.
Oh, my. I see Warden McQueen.
Warden McQueen.
So moved, so seconded.
Decide.
Seconded
Thank
by
you.
Councilor Desai. Everyone is in favor. Thank you again, folks.
Thank you.
Take care. Bye.
Bye.
Thanks. Bye.